So I'm going to start with individual treatments for individual mutations, and then say that, and just start with the point that we talk about EGFR mutation positive, but we have known for a long time that it's more nuanced than that, that there are two activating mutations that are far more common and account for about 85 to 90% of the mutations, and those are an exon 19 deletion, accounting for here 47%. It varies somewhere in the range of 40, 45% for each of these. And then exon 21, also known as an L858R substitution, in another large number of patients. So together they come out to about 85, 90%. And then there are a group of rare mutations, exon 18, exon 20, and even some combinations of mutations that can be seen in the same patient. You can see that that accounts for just even together, a sliver that's pretty narrow, a patient here and a patient there. But it's a mistake to presume that these are all the same. In fact, not that long after these mutations were first discovered, Dr. Riley was one of the people who helped identify that there may be relevant differences between the activating mutations in 19 and 21. Some of the work that he did is on the bottom of this slide, and at the top is work done in Boston that showed the same concept that exon 19 patients may do somewhat better than the patients with exon 21. Now, that is not to say that exon 21 patients don't and can't do very, very well, but perhaps not as well. On the other hand, there have been other studies that suggest that the differences are not very meaningful. This is work that was published in the New England Journal now 5 years ago, looking at patients who received gefitinib in a trial comparing gefitinib to chemotherapy. And this is a Japanese population in this study, and some others have shown not very impressive differences between the patients with exon 19 or exon 21. So it's been a complex issue, and it's really been one that we haven't paid that much attention to over most of the last decade or so. It's become a little more relevant in the last couple of years with a few trials. One of them is here. It was published earlier this year in JAMA Oncology, and it looked at one of the important trials called EURTAC, which was a European study of erlotinib or Tarceva compared with chemotherapy, and it actually included in that study serum-based testing. This is one of the studies that highlighted the potential utility of serum-based testing for EGFR mutations and built that in. And a reasonable subset of patients on the trial had serum collected. And the study showed that the patients, this is over here, the patients with an exon 19 deletion seemed to do somewhat better, not remarkably different, but better than the patients with an exon 21 mutation. And when you looked at the patients, depending on, this is in tissue actually, and this is in serum. And when you look at the serum, patients with 19 deletions do better than 21, and those where they couldn't get the test completed fell in between. So interesting, didn't lead to a sea change in practice, but provocative. There was also a study that I have been intrigued by and hasn't totally changed practice that looks at Tarceva with or without Avastin added to it. It's a Japanese trial that was published earlier this year in Lancet Oncology, and it doesn't include in the final publication this interesting subset check, subset analysis of patients with an exon 19 deletion or exon 21 mutations that shows actually in this group of patients that the addition of bevacizumab or Avastin to Tarceva or erlotinib was associated with a shift of the curves in the favorable direction. But there's a little difference in outcomes in terms of how long patients went with progression-free survival, more favorable for exon 19, as you can see in the actual numbers, even though both groups benefited from the combination. So one of the arguably more influential trials that really highlighted the potential clinical utility of the exon 19 versus exon 21 distinction is with afatinib or Gilitrif. And 2 randomized trials were done comparing afatinib to chemotherapy. One done in Asia, compared with cisplatin and gemcitabine, and another study done globally, afatinib compared with cisplatin and pemetrexed or Alimta. And both of these studies showed a benefit in terms of overall survival for the recipients of afatinib relative to chemotherapy only in the exon 19 patients, and the patients with chemotherapy actually had a modest trend that was not statistically significant in favor not of the afatinib but chemotherapy. So really suggesting a disparity where it really seems to matter which particular activating mutation you had, and that the patients with an exon 19 mutation really seem to be better served by getting afatinib, at least than chemotherapy. And the question is that really an afatinib effect, or is that perhaps applicable to other agents, other EGFR inhibitors like Tarceva or erlotinib or Iressa, also known as gefitinib? And there was a study presented at ASCO and then published in Journal of Clinical Oncology that looked at the results in patients with an exon 19 mutation or an exon 21 mutation. And here, if the box is on the left side, it suggests a benefit for the EGFR inhibitor. Still on. And what you can see is that there's really no meaningful difference, a slight trend toward better outcome in the patients who got EGFR inhibitor. But for the afatinib studies, it really moves over to the left more than that. And you can see that it really seems to possibly be an outlier there. On the other hand, when you look at the exon 21, there you go, we're back. When you look at exon 21, no clear pattern here and no clear pattern of particular benefit with afatinib. So perhaps a relevant difference there. But it's still a controversial, somewhat open question, and I think the best way to answer this is going to be a direct head-to-head trial of afatinib compared with another EGFR inhibitor, and that study has actually been done. It's called Lux-Lung 7, and that was done partly in Asia and partly in Europe, and it directly compares afatinib to gefitinib in patients with EGFR mutations, and we should be getting results from that next year to help us answer it. It might not give us a conclusive answer, but it should really help us learn whether patients with a 19 mutation clearly do better with afatinib or comparably. So I want to turn briefly to the rare mutations, and that may or may not be relevant to folks here. This is really largely looking at first-line treatment, but I did want to point out how potentially relevant the actual individual mutations may be. This is a study in Japan looking at 2 databases of over 16,000 patients, looking at what type of mutation they had, and found that 3% had a mutation in EGFR in exon 19. Now, the potential relevance of this is that they looked at the preclinical or lab-based work on cell lines of cancer cells with an exon 18 mutation and found that there were real differences in how well EGFR inhibitors worked in the exon 18 mutation cells. And specifically, afatinib and another one called neratinib, which was studied a few years ago and has really gotten tangled in legal issues and isn't moving forward, seem to have particular activity in exon 18 mutations that was more comparable to its effectiveness of these drugs in exon 19, whereas many other drugs had no remote activity against the rare mutations compared with the common ones. So this is potentially relevant in that there's a little bit of clinical evidence when you look at the work that's been done with neratinib in patients with the EGFR mutations. The 3 patients with the best response, that is the bars going the furthest down, those are patients with exon 18 mutation who got this drug. And there's also some work with afatinib in patients with rare mutations, and this is a publication from earlier this year, just a few months ago, looking at afatinib results with in various trials, in the 2 that I mentioned and one other phase 2 study, where they collected 100 patients with rare mutations from all of these, and they broke them down into 3 main groups, including rare mutations with point mutations in exon 18 to 21, exon 20 mutations, and then another group with, this is actually includes T790M mutations, and also patients with what's called exon 20 insertions. And so there's 3 different groups of these rare mutations, and there's very different results depending on which group that you were in. And basically, a significant fraction of patients had a benefit with nice downgoing bars demonstrating response to afatinib if you were in group 1 especially, or group 3, but if you were in group 2, the light blue, you were much less likely to have a big response, and that's largely the T790M positives. Here the red diamond represents the duration of response, and you can see that some of these are lasting for a year and a half, 2 years or so. So you can have a very good response potentially with these rarer mutations, and this is only looking at afatinib. Whether it applies to other EGFR inhibitors is not as well known, but some of the preclinical work suggests that there may be relevant differences between the mutations. And when we look even further, you can see this is the results by group. And then when you break down group 1 into a few different patterns of mutations, there's differences within group 1, for instance. So the more granular you go, the bigger the difference. This is some work that Dr. Riley did with a colleague, Dr. Helena Yu, at Memorial Sloan Kettering, that was published last year, that looks at how patients did if we found that they had a T790M mutation called a de novo mutation, that is not acquired months or a year after starting an EGFR inhibitor, but at the time of diagnosis, showing that the median progression-free survival was a month and a half, or basically the first scan you did, you found progression. Patients, fortunately, on average, lived longer than a year despite that, but it really suggests that this EGFR-based approach doesn't apply, at least with the drugs that we were using at this time, gefitinib or erlotinib, for patients with a de novo mutation. A little more work, this is coming out of India, looking at patients with T790M and other exon 20 mutations, and basically when they looked back at their work found that they had poor results, but there were real differences depending on which type of exon 20 mutation you saw, and some patients had responses and a longer survival than patients in other groups. And so really the point is the exact mutation tends to matter. There's a nonprofit group called mycancergenome.org, and they have a website at that URL that allows you to look at what is known about some of these rarer mutations. And I think that this, along with the slowly growing published experience with some of these, is going to make it possible to have something insightful to say and suggest for patients with rarer mutations in the coming years. So this is a growing experience of my one-off with treating a patient with a rare mutation and putting it out there so that we might collect 5, 10, 20 patients with a rare mutation and really see a pattern of them responding well to this EGFR inhibitor and not that one. So we will see. My conclusions then for this section is really to say that there are clinically significant differences among the EGFR mutations. And over the years, it was a big breakthrough to find that EGFR mutations matter, but then even more so to realize there's differences among EGFR mutations. And for much of the last 10 years, we'd really minimized the differences within activating mutation. In some cases, it may not make a difference. With some drugs, it may. And I think it's going to behoove us to look with a more granular eye toward what specific mutations people have and how best to treat them. That goes with the common mutations. It goes with the rare mutations, including de novo T790M, for whom we'd really want to not choose at least some of the older EGFR TKIs, perhaps some of the ones we're going to talk about more for acquired resistance over the rest of the hour, and that some of the rare mutations can have very good responses to at least some of the EGFR inhibitors that we have available now, whether these are broadly expandable, generalizable to all of the EGFR TKIs or not, we're going to need to learn. But it's not that rare mutation is some nebulous black box for which we have nothing to suggest. So I think we're going to be learning more and more. And for the next 45 minutes or so, Dr. Riley and I will largely be focusing on this question of T790M and how it applies in the acquired resistance setting. So thanks very much.